Now.
No, we've already started recording.
Has started recording.
Okay, let me just say hello to everybody. Good morning on March 7th. For those of you that are in the Olympia area, this is fondly known as the last week of legislative session. And so we're real anxious to have that wrapped up and see all the gifts that have been provided to us in terms of supporting behavioral health. And in this case, particularly substance use disorder outreach, treatment, and recovery. So it's a big week for us here. And hopefully you're all tracking some of the developments on that front. We do have some, at least one new member today we'll introduce. And they will get right into some meeting discussions about content that we'll be putting into the plan going forward. So we're thrilled that you're all here. We imagine some of our legislative partners may not be able to make it today given their duties in the last few days here, but I'm going to turn it over to Michelle again. If I haven't met you, Michael Langer, Deputy Director with the Division of Behavioral Health and Recovery, and I chair the SURSAC committee that came out of the Blake bill last year. So we're real excited to have what will be our fourth meeting now, having kicked off in December and had a couple already this year. So Michelle Martinez is our lead staff person for the committee. Most of you have been in discussion with her over the last few weeks and months. So Michelle, I'm going to turn it over to you for taking roll and moving us along.
Sure. All right, so I wanted to start with a quick disclaimer that this meeting is being recorded and will be posted to the 5476 webpage. It is open to public disclosure, so please do not disclose any private or confidential information during the meeting. And as for guidelines for public feedback, there will be time at the end of the meeting for feedback in the last 5 to 20 minutes. Each person who wants to share will have about 3 minutes to provide feedback. Non-committee members will remain muted until it is time to provide that feedback. And HCA staff in particular are free to participate in the chat, but should not be using the public feedback time to provide feedback. There are internal meetings for your input instead, and feedback that is not provided at the end that you wish to provide can be emailed to hcaesb5476@hca.wa.gov. And we'll just move right into roll call here. All right, so Michael Langer is present. Amber Leaders.
Yeah, I'm here. Good morning.
Good morning. Senator Dingra. Senator Braun. Representative Davis. Representative Griffey. Caleb Bantagreen.
I think he's here.
Yeah, I thought I saw him.
Yeah, might be on mute.
Oh, okay. Caleb, are you here? Give a couple more seconds. Okay. Kiera Fisher. Alexi Orr. Okay. If you could unmute and say present, that helps. Amber Daniel.
Present.
Thank you. Brandy Flood. Cheryl Raysar. Chad Enright.
Present.
Thank you. John Hayden.
Present.
Thank you. Marshall Glass.
Present.
Thank you. Hallie Birchinall. Teresa Atkinson.
I'm here.
Thank you. Sarah Gillard. Donnell Tanksley.
I'm here, and good morning.
Good morning. Malika Lamont.
Present.
Thank you. Addie Adwell.
Present.
Thank you. Kevin Ballard.
Present.
Thank you. Hunter McKim.
Present.
Great. Kendall Simmons.
It looks like she's working on getting her sound back, and I'm just walking her through that for you.
Okay. Okay, great. And Representative Taylor. And Representative Mossbrucker. Okay. Thank you all. We'll try to track if people are coming in after roll call as well.
It looks like Rep. Davis and Senator Griffey also joined.
Have joined. Okay, great. Thank you. All right, so I'm going to go ahead and hand it back to Michael Langer for introducing Kendall Simmons, our newest committee member. And yeah, go ahead.
Thank you, Michelle. Also, in my enthusiasm for what's anticipated this week with the legislative session, I failed to take a moment and acknowledge our friends in the Ukraine. I think we should start our meetings this week just acknowledging the suffering that they're going through, and know that our prayers and well wishes and so forth are with them, and ask that we all keep them in mind as we proceed with this meeting today. I imagine everything else that they're going through, the trauma and such, will definitely impact their mental health and most likely behavioral health in general. So let's keep them close to ourselves. With that, I am certainly happy to introduce Kendall Simmons, who has joined us. She's a young person that's agreed to serve on our committee, and it'll be our second youth representative. And so, Kendall, if you wouldn't mind, as folks have joined the committee, we've offered a minute or two for them to give a little bit of their background and where they live and what you hope to contribute to the committee. So if you can go off mute and introduce yourself, that would be great.
It looks like she logged off to try to log back into her phone. So I do believe that that phone number that's in the waiting room or was just admitted could be her.
Okay. Kendall, can you hear me? We may have lost her. So why don't we go ahead then with our next item, and maybe between the agenda items, we can pause and have time for Kendall. Unless you got back on already. Kendall, one more time. Okay, let's go ahead and proceed. And I believe next up, I'm going to turn it back over to Michelle, who has a little bit of follow-up from our last meeting and an ask of the committee, I believe, too, on some more feedback. So Michelle, take it away.
Yeah, so one of the suggestions that had come up in the discussion last month was to have more availability for peer respite for SUD. And as we were reviewing that suggestion internally, it became clear that we needed more information about what that would look like, what that means. And so if we could elaborate on that idea, that suggestion, that would be really helpful for us to assess feasibility and how to make that, how to make that happen a bit more. So, so what other, if there's ideas for what that means, let's just start there. Like what is peer respite for SUD? What does that look like exactly? I see it. Sorry, I see it's a hand, but I can't see who is raising it for some reason. Oh, sorry, Representative Davis, go ahead. Yeah.
Good morning, everybody. I think that may have been me, or if it wasn't me who made that suggestion, I would have heartily dittoed it. So for anyone just level setting, I know HCA is very well familiar, but maybe not this whole room is familiar. In the not so distant past, the state got interested in mental health peer respite, basically typically a single family residence, typically, 6-ish people at a time or less, staffed exclusively by mental health peers as an alternative to ideally avert hospitalization. There's a lot of models from other states. That a FIA house comes to mind. I forget what state it's in. And Rep. Schmick had a bill, I think it was 1349 in 2000. I don't remember, in the last couple of years, that created, I think it was 2019 or 20, created different behavioral health facility types in Washington, one of which was mental health peer respites. But we have no such equivalent for SUD. And my thought, and this all might be terrible ideas, but my thoughts include the following. So something similar, single family residence, which are awesome because you don't run into the siting issues. If you're using a single family residence in a neighborhood, you tend to be able to skirt some of the siting issues often. But, there's a couple ideas that I have about that. One would be you could operate it where people are actually taking sort of kind of like an ambulatory detox, as in people are taking prescribed outpatient detox medications that they're self-administering, and they would it wouldn't be medical. Obviously, peers are not medical, but it would be a place to lay their head and have kind of have their spirits be filled while they're also going through the physical and psychological withdrawal symptoms. But again, you'd have to be really thoughtful about how you did that because of it would obviously not be a medically managed facility. But these would be patients who theoretically would be safe enough. A physician would have deemed them safe enough to withdraw at home and prescribed medications. The other thought that I have related to SUD peer respite, and again, at some point we should really just stop separating SUD and mental health, frankly, but currently mental health peer respites don't serve people with SUD. The other thought would be, a lot of people with SUD, anyone from the rooms would tell you that the relapse happens, long before the drink or the drug. And people know, like, people are super aware of what's going on in their lives, and they can see the chaos train coming. And I've had people in early recovery say to me, gosh, I just wish there were a place like I could escape for a few days to just like calm down before I end up using, because I know I'm about to use, like, everything is, crashing down on me. There's a CPS case that's stressing me out. I got in a car accident, this, that, or the other thing is happening. And I'm just, everything is so shaky, and I just need to reset so I don't use, and I know I'm about to. That would be another thought. And again, these are like, middle of the night musings of mine that may be terrible ideas, but that is what I had in mind when I said such a thing.
Thank you so much. Any additional thoughts about that, or what we can include specifically in the plan to help support more of that? Yeah, go ahead, Amber.
I actually just Googled what is peer respite, and I found a really good definition. I think is kind of like, in layman's terms, it's kind of like a bed and breakfast for people who are in crisis. It's in a home-like environment. It's open 24 hours. It's staffed by people with lived experience. And it's for the purpose of them to take a breath and figure out next steps to move forward and avert crisis, and on a bigger scale. Would that be a good way to sum that up?
Very much so.
Okay, great. Thank you. Any other thoughts about peer respite for SUD specifically? And what we should be looking at as part of the plan to support that?
It would be helpful if there was a nurse on staff, especially if somebody is on, or a nurse practitioner, or, you know what I mean? I think that would be at least somebody that's EMT certified or something.
That's a medical support. Yeah.
I think it would be helpful, this is Michael, it would be helpful for your thoughts also about, because I like the idea of when people would use it. I can kind of see where there may be a time when somebody's waiting for a bed to open, and they just need a couple days, right? If that's the route that they're taking. For others, like Rep Davis mentioned and others, that there might be a triggering moment that if they can just get to a respite for a couple days, may prevent the relapse from happening. And so having that available sounds like a really nice addition to our continuum. But I see other hands up, so anxious to hear what other thoughts are. Can you see the hands up, Michelle, or do you want me to call?
Oh, I'm sorry. Yes, go ahead, Representative Griffey.
Yeah, thank you. I like Rep Davis's idea here, and I want to caution those that are talking about a nurse or some sort of practitioner. If we don't keep it loose like Rep Davis is talking about, we don't get it for 10, 15, 20 years, right? So we got to really think outside the box to help people. She wants to give somebody a place that, it escapes me now. But anyway, a place to go to. It used to be that you would call your sponsor, at AA, that's where I was trying to go. You would call your sponsor, but this would be a little bit like that. You've been released with medication to help you with your withdrawal symptoms. You're on your own recognizance, but maybe you just need a buddy to help you through it. That's kind of what she's trying to get at, because I just want to urge people, if we're talking about having a medical practitioner there, which I agree would be nice, it'll never happen. Well, in our lifetime, probably. And it would cost billions of dollars. That's my 2 cents. Thank you.
Go ahead, Teresa.
Sorry, I have too many computers going right now. I just wanted to, along the same lines as what Representative Griffey just talked about. There often is a disconnect between the need that we're trying to meet and the available funding or the ability to bill for such services. RNs, psych ARMPs, things like that. People like that tend to cost quite a lot of money. And then if we're just doing, kind of like a sponsor type of thing where I'm just going to go and hang out in a place that's safe for me, we still need to supply people who are capable of meeting the needs of people who are, in crisis, whether it's a relatively moderate crisis or, a mental health crisis. You're going to need folks on that are trained and able to manage those needs in a way that is safe and doesn't create liability for the program. So just keeping in mind, what does all of that cost and what do we bill for something like that? Because if we make it sound too peer, we tend to not get paid very well for it. I'm, representing the SUD provider here. So how do we make sure we're meeting the needs in a way that's safe while also able to bill for something that's going to be fundamentally secure and actually able to meet those needs?
This is Brandy from Evergreen Treatment Services REACH. What about the sobering center model? I mean, it's not a peer model, but it worked for many, many, many years. Having a secure place where there's medical providers, there's outreach workers, there's places where people can get stable and be healthy. Why not thinking about that type of model? And, you do end up having, I don't like the term peers, it's as if they're less qualified, but you can hire outreach workers and workers that have lived experience, that have the skill to work with that population.
Thank you. And Amber, it looks like you have something to say.
Yeah, I was thinking, what if even like what Teresa was saying, we just offered training for the peer support that work there, because that's always an option too. We of course we want people that are CPR certified. Of course we want people that are mental health first aid certified. Of course we want, that kind of stuff. And I also was that Malika or Brandy? It was Brandy Flood, right? That just talked. Anyways, the idea that I was thinking maybe even a CNA. It doesn't have to be super and there is liability when you come into that. And the sobering center model is something that, especially in Walla Walla, we need. We need a place where, because there's no detox here, and there's no detox for miles. And there's a mental health crisis place, and that's it. And like if people want to go to detox, they have to go to Yakima or Spokane.
Thank you, Amber. Go ahead, Malika.
I think what I'm hearing is that there needs to be a continuum of options, and that we do have actually a lot of things that it sounds like that we could do that could be creative. One of the along the continuum from what Brandy's describing to having places that are single family homes that people can go to. One of the things that I'm also thinking about is there a possibility to create a collaboration with low barrier clinics that have nurse care managers, so there isn't necessarily a nurse on site at the peer-based respite or at the sobering center, but there's access that increases the access to medications, at least for opioid withdrawal, and potentially other medications, in order to help people navigate that. And since we are popping up with more low barrier models, if there was funding to maybe increase their scope of practice, that would not be a huge lift. You've got already established services, and then marginally increasing their scope of practice to be able to provide other forms of medication, prescription access to other forms of medication, and then standing up these peer models. I think there's a lot of room to make stuff happen.
Thank you, Malika. We have another 4 minutes dedicated to this, but if there are no additional comments, we can move on to the next item. Oh, I'm sorry. Go ahead, Representative Griffey.
I'm sorry, I have a lot to say today. Those of you that know me, I'm a professional firefighter, and so the sobering center model is amazing, and I would like to see a sobering center in every community. Again, one of those things that's going to be impractical to expect happens quickly. So I think we need to have a whole open arms approach to say we have to have a continuum. Somebody that might have graduated from a sobering center but just might need help. That's kind of the idea we're talking about here, is like they're on the pathway, they have the tools that they need to succeed. However, maybe they don't need to go to a sobering center. Maybe they just need, like I just text Rep Davis, a buddy to help them through a hard point, like a sponsor. I think that's what we're talking about, but working towards having sobering centers in every community to where we don't have to drop them off at EDs any longer, it would be, I think, the gold standard. Thank you.
Thank you. Any other comments?
Kendall Simmons also joined, or looked like she did.
She is. We'll get to her in a moment as soon as we finish up this discussion. Any other thoughts?
Okay.
Should we move on, Michelle?
Everyone's feedback. Yeah. Sorry, go ahead, Michael.
Okay, thank you. And thanks for the feedback. I heard at least 2, maybe 3 different potential models there to sort of frame out as the plan develops. So really appreciate your feedback here, and hearing a lot of voices, which is great. So please share what you would like to contribute. And think across, as these ideas start forming as well, think across the age span and the population that we serve. Sometimes these models will work for adults, but you need a separate one for young people and things of that nature. So we have to kind of keep all that in mind. But speaking of young people, Kendall, welcome. We reserve a couple minutes for new members to introduce themselves, let us know where you're from, and what you hope to contribute to the committee. So really appreciate you being here, and sorry you're having a little bit of a technical difficulty this morning, but it looks like we got it sorted out. So the floor is yours. Please let us know who you are.
Thank you. Yes, I was having technical difficulties. It's all sorted out now, so thanks for sticking with me. My name is Kendall. I'm currently a student at the University of Washington in Tacoma, and I'm studying for a master's of social work degree and hoping to be a SUDP in the state of Washington. I'm here as a youth in recovery. So I'm really excited to give my input as someone who has a lot of experience with not only substance use disorders, but also trauma and other interconnected experiences. So I'm super excited to be here, and I really appreciate you all having me. It's nice to meet you.
Thank you, Kendall. Boy, that's music to my ears. I'm sure most on here. We have folks eager to join the field and to become a SUDP. That's cool. So thank you very much. Don't hesitate to chime in on any of these topics today or ask questions. And if the pace starts to go a little quickly, it's okay. Just rate. You know the hand feature, I hope, on their computer.
Yes, thank you.
All right, perfect. I'm sure you could teach the rest of us how to use these things. So please don't hesitate to raise your hand and let us know what you're thinking. Hunter is also on here today too, again. So Hunter, welcome. And we'd love to hear from you guys throughout the meeting. So with that, I think we're going to go now into some conversation about diversion from the criminal legal system to community resources. And I think we're going to have a presentation on the sequential intercept model, and then we have a variety of questions for you. So on my agenda, it doesn't have a name, but I think maybe Tony's going to do part of this. Michelle, who do I go to next for this topic?
Oh, I don't think we had a presentation plan per se, but I do have a graphic to pull up to help familiarize folks with the sequential intercept model. There was a bit of information sent out in the email on Friday, but understandable if people haven't had a chance to familiarize with the model. So I'll go ahead and share a little infographic so we can get on the same page about what that is.
Yeah, let's do that. And then I think maybe I missed my own cue here. So I think maybe I'm leading people through these questions, and that's fine if you want. I can do that. So you take the intercept model, maybe give us a high level on that, and then we can get going with the questions.
Sure. So there's essentially there's these 5 different, it looks like, intercepts where there's opportunity to divert from the criminal legal system into community-based services. And so this conversation is really about, where is it appropriate to be, moving people out, and how do we do that? And where are things already supported, and where do we need more supports? And so just looking at these different phases of someone, moving from interaction with law enforcement to prison, and seeing, where along that journey there is room and space for intervention and to help get them into more appropriate services for SUD recovery, mental health recovery, and all of those things that are more conducive to, to true recovery, and not having people in the legal criminal system and prisons that are not really for them there. So can everyone see the shared screen with the model? Thumbs up. Okay, great. And I'll enlarge this a bit. Oops. Yeah, so take your time taking a look at that, but as ideas come, whether that's about, the current situation that we need to be aware of, or ideas for improving how we can divert to community-based services, please go ahead and speak up.
Thank you, Michelle. And I'll just lead us through the questions, folks. We have about 40 minutes or 45 minutes. This is the bulk of the meeting today. And so we definitely want to hear of programs, strategies, innovations that you're aware of, whether they're in your community, in the state, or the region, or national, international, really. This is where we want to pull from you your best thinking and experiences so that we can build that into our plan as well. So it looks like there's a hand up from Malika before we get going here. Malika, did you have a question or comment?
I guess I had a little bit of, I don't know how you'll classify it, but maybe it's more of an ask for how we frame this discussion. I don't think that it's not neutral where we meet people along this intercept. It's important to get people out of the criminal legal system as soon as possible and get them engaged in treatment services. And it's not neutral along this intercept. Like the sooner that we can get them out, the better it is for the individual, the better it is for pocketbooks, all of these different things. So I think that I just want to throw that out there as like part of the framing conversation. It's important anywhere along here to engage with folks and get their behavioral health needs met. However, it is not neutral where that occurs. So I just wanted to emphasize that is kind of like a framing of this conversation.
Thanks for your thoughts, Malika. I think Donnell Tanksley. Donnell, did you have a comment as well?
Yes, and thank you. As I looked at the model and I thought about from a law enforcement perspective, how we intersect in these different phases, if you will. One thing I think that this group, perhaps what we should advocate from a law enforcement perspective is the amount of training that we give law enforcement officers and dispatchers, for that matter, with regard to crisis intervention training. As you may know, that currently a law enforcement officer in the state of Washington is really only required to do 2 hours of annual CIT training. Now that they do have a 40-hour course, which is the CIT certification course, which is a voluntary course. So I would be an advocate of trying to make the 40-hour course mandatory, not just a 2-hour refresher. Now, of course, there are other training sessions that's available, but I think requiring every law enforcement officer of general jurisdiction in the state of Washington to have the certified 40-hour course would, I think, help in the understanding of the trauma and the tragedies that people go through. And as a law enforcement officer, it's our duty and responsibility to arm ourselves with as much knowledge as possible. So that's my thoughts.
Thank you for being here and for your contribution. Really appreciate the comments. We'll take note of that. Next, we'll go up to Brandy Flood. Brandy, do you have a comment?
Yes, definitely. And I definitely come from a client-centered point of view, so you guys will hear that in me. The further you go down into the intercepts, the less autonomy the individual has to make changes. And the only way to make long-term changes for them to have some autonomy and some power in it. And so you almost have to start at intercept 0 if we're going to make profound change in communities, especially with these drug crimes. And so once they start to get in the system, and we start later there, the system has all the power. This way, some of the power is leveraged with the community and the client you're serving. And so any program we have, I think, needs to start at intercept 0. I know we've made a lot of breakthroughs with clients and changing people's minds with LEAD by coming at intercept 0. It's almost transformative to the client and even to the officer who appreciates somebody coming in the moment when they see that this is not the right way to go. Why even do all that paperwork and all that when they could get services right in the beginning? That's just my point of view from experience in working with LEAD.
Okay. Thank you, Brandy. Appreciate your comments there. Representative Davis, you're up next.
Thanks. I just wanted to expound a little bit and thank Chief Tanksley, aka Tank, for his contributions. And I did want to let the group know about 2 pieces kind of related to law enforcement training. So in the state's response to the Blake decision 5476, there was, and I'm sure there's a lot of moving parts in that bill, and hopefully along the way this committee can get different updates about all the many moving parts, but one of them was actually training to be inserted into the basic law enforcement academy BLEA related to not I think it'll actually be part of the crisis course that is offered at BLEA, but related specifically to interfacing with persons with a primary substance use disorder. So that is forthcoming. But again, that legislation it requires that training for new officers. So in order to address existing officers, the House had $500,000 budget proviso this year to the Addictions, Drug, and Alcohol Institute at UW to basically take what they are developing, which is very much informed by people with lived and living experience, to teach law enforcement how to interface with this population, to take that and expand it regionally for existing law enforcement. And they're using like a co-trainer model where they've got a local law enforcement officer and then a person with lived experience who's kind of co-training. And hopefully the Senate will acquiesce to our position and agree to include that. But I do want to just note that there is some significant work happening in the space related to how to train law enforcement to around SUD. For folks who are familiar, the CIT training has a heavy focus on mental health and not so much on SUD. So I'm excited about the progress in that space, and hats off to the partners, the CJTC and the UW BHI and ADAI who are leading that effort.
Thank you, Rep. Davis. Appreciate that and the support, obviously, throughout session. And we have 3 more comments, and I think we'll move on to the questions. So Marshall Glass, you're up next.
Good morning, everybody. I really think, and I understand that the MOUD piece is mentioned in 3 places, but I think there needs to be more of an emphasis on that. I know there's some issues with folks actually getting access to medication-assisted treatment while incarcerated. I know there's definitely concerns with continuity of care as they're released into the community and connected to various treatment options. And beyond that, I also believe there needs to be more of an emphasis on legitimate co-occurring services being provided while incarcerated as well as upon release.
Thank you, Marshall. Good comments. Just a real side note, we're very close to having contracts in place that will put more MOUD medication in about 22 jails across the state. So I know they're not the first 22. There have been leaders out there doing this, but that's certainly a nice step in the direction of having everyone get there. So we're thankful for the resources that came through to do that. Next up, we have Kendall. You're up. Do you have a comment?
Yes, I just want to add to what Brandy and others said about Intercept Zero, and just emphasize the importance of that, especially because I think people are more successful when they have autonomy. And once that arrest is made, typically it looks like now treatment is mandated, and if you miss appointments or whatever, you might be reprimanded and or penalized. And yeah, I had something else to say and I kind of lost my train of thought, but I did just want to add that I think people are more successful when they have autonomy over how their recovery on what it looks like.
Thank you, Kendall. If you think of your other point, feel free to add in. We're going to take 2 more, and then I'm going to stop just because we have to get to the questions, folks. So Kevin Ballard, I believe you're up next.
Thank you. I heard some very positive information coming from Tank. I am a former law enforcement officer, having interacted with a number of people dealing with substance use disorder. I see a delineation. I certainly want the Intercept Zero model, the goal being complete diversion from interaction in the criminal justice system. And I see that working for those dealing with central nervous system depressants specifically, but my interaction with those dealing with central nervous system stimulants, methamphetamine, and other such drugs, even phencyclidine, that experience interacting with those individuals tended to lie on the more violent crime and more impactful on the community vis-a-vis the criminal justice system.
Kevin, did I lose you or is it me?
I think Kevin froze.
Okay. Are you back, Kevin? You froze there in your last comment. So you were talking about the violent crimes that comes with some of the use, and then you cut out. So you want
If you
to?
got me back, do you have me back?
Yeah.
Okay, yeah, basically that's my point in question. You know, the zero intercept, that's where I'm at wholeheartedly. And with behavioral health, that's the model that I'm, you know, supporting both with NAMI and with but I'd like to see what the approach is from the substance abuse behavioral intercept with these professionals seated here on this board. Do they see a delineation?
So for those that are in the system, how can we continue to try to intervene earlier, but may not be able to keep everybody out, but how do we intervene as we go along? So thank you, Kevin. Appreciate it. And Amber, we're going to close up with you and then get to the questions. Amber Daniel.
Yeah, thanks. So I was just gonna say one thing I don't see up on this continuum is stuff like harm reduction upon release from jail for people, like maybe like Narcan, and stuff like that, especially for people with presenting problems of substance use disorder, that maybe that could save their life. Connection to that. And then we actually do have a recovery pod here in Walla Walla in the county jail. And it's like a therapeutic community. It's pretty cool. And it's really helping people. I think that incorporating a recovery model or when people are incarcerated, I think really is something that needs to happen more across the state. For people, of course, voluntary. I think that recovery is a self-directed thing. And like Kendall and I forget who else was saying about, you know, autonomy. You know, people don't have buy-in unless they have that autonomy. And to be honest, I didn't even know about autonomy until I got into recovery. So I didn't know what that really meant, you know. And for a system that's designed to take your choices away, it is so important to give those back. So we're just seeing some really good success with that recovery pod model, and it's working out really well. So if anybody has any questions about that, I can talk about that a little bit too.
Thank you, Amber. I'm going to transition. Malika, I see you too, so I'll give you the first word once I get the question out, because that started to get there, Amber, a little bit. The first question is, what diversion programs are you aware of that you like and are working? So this could be at the very front end, before that connection's made or once the connection's made. But either way, what type of diversion programs would you like to see us consider promoting the models, I guess, in the plan as it comes out? So Malika, do you want to start us off, and then we'll see who else wants to comment.
So, well, I guess my response that I was going to say aligns with this as well. I think we need to, you know, part of this conversation is really having meaningfully talking about addressing social determinants of health, because there is, you know, it's good to have MAT, but there are some, to everyone's point, when we're speaking about stimulants, we don't have a meaningful MAT response. However, when we start meeting people's social determinants of health and we start creating meaningful responses to that, people start to stabilize. It's easier to do that earlier in the intercept. Obviously, I work with the LEAD model that has been proven to the law enforcement assisted diversion, let everyone advance with dignity. That's what the acronym stands for. It dwells at the 0 and 1 intercept, and it is all about increasing autonomy for the individuals that we work with. And it's across all behavioral health, so not just substance use disorder. But I think that it's important to start addressing the real needs that people are expressing, and again, engaging them in that self-determined process is crucial.
Thank you, Malika. Other thoughts about models? We heard LEAD. Are there other models out there that folks would like to bring forward today as ones that you favor, ones that you've seen working? Okay. Amber, did you have a comment or a model?
Yeah, we have a contract with the jail where we do outreach before people are sentenced. So we have like a virtual thing because I work at a recovery community that does peer support. That's my job. I'm a peer support specialist. And so like twice a week we just do a half-hour thing where people that self-identify as having substance use disorder and that could be getting out really shortly are introduced to the services we provide over a virtual platform. So we have the opportunity to put together a packet that we give to, there's a social work case manager in the jail that, deals with the inmates and gets them their materials. And we provide them with a planner for their first week out. We provide them with a welcome to recovery letter, from, a couple of us here that work at Trilogy that talk about our experience with the criminal justice system and finding recovery and, what it's done for us. And also like pamphlets that describe our services. And then we go through that packet with them over the course of 45 minutes, half an hour. And, answer any questions they have. These people sometimes are waiting to get out of jail or go into treatment even. Some of them are ARC participants or adult recovery court participants. Some of them are, but they're all people that are pre-sentencing. And I think that just getting that outreach piece in about what services are available in the community and maybe helping people plan for their first day out is so important.
Back to my list here. Thank you so much for that, Amber. Okay, folks, this is your time to promote additional diversion strategies, either, prior to making contact or once you're in contact furthering along. How can we divert folks from furthering along the continuum? And Kendall, do you have a comment on that regard?
Yeah, I just want to say that I do favor housing first projects. I know that they're super effective, and I know that housing is really a huge issue everywhere, but especially here. And, it's very hard to be in recovery when you don't have a safe place to lay your head. And, I don't know what that type of project costs, but I just know that it's really effective and I think really necessary.
Thank you, Kendall. And yes, having a warm place and a roof over your head and some of those primary necessities is really critical. So thank you for that. Caleb, let us know what you're thinking in terms of diversion strategies or models that you'd like us to consider.
Good morning. My I just want to expand a little bit on some of the conversation around low barrier access to buprenorphine that Malika mentioned. That's something that Olympia Butte Clinic is involved in. We've been involved in that as well. In King County, it's become much more common, co-located with syringe exchanges. And so I want to mention two aspects of it. One is that I think the co-location and integration of services with harm reduction is super important. It provides an engagement point, it provides harm reduction, and I think it also really sets a very, very important tone because it's more than it can, but I think we need to think about harm reduction is not just about supplies, but really about people and engagement. And we're seeing that in the safer smoking, and we put out a couple of weeks ago, the new safer smoking supplies down in Tacoma saw something like 700 new clients in the first year who they'd never seen before. So in terms of the quote diversion, I think we can think about harm reduction as a form of engagement, which can be also a form of diversion. And also to the earlier point about concerns about stimulants, which I understand, we're working on expanding the model, the nurse care manager model, the low barrier model, to include stimulant use disorder and behavioral health supports, which are the best evidence-based services we have right now. So I just want to put that out there, sort of thinking about diversion in kind of a more holistic way. And I really like to think about diversion as a place that people want to go, and perhaps they'll even divert themselves without us needing to intervene.
Thanks, Caleb. Appreciate that. And we're going to call on Malika in just a moment. I would like you to think not only maybe are there models that you're aware of, but are there strategies that you've thought of that you may not have seen the model fully fleshed out or actually implemented even, but you'd like us to consider thinking about as we put a plan forward together. So think about that. And Malika, you have another comment?
Another model that we've been experiencing some success with is the Just Care model in Seattle, where individuals are, outreach is done with individuals, and when they choose to, they come into, it's housing, hotel-based housing, low barrier harm reduction model. People are then engaged in wraparound case management, and they identify the goals that they want to progress along, and then they're connected with services in order to further stabilize them. And it's completely based on harm reduction. And people eventually move along that continuum of behavior change. So that's another one that I think that is shown a lot of promise.
Thank you, Malika. Appreciate that and bringing forward another model. Marshall, go ahead and let us know what you're thinking.
I also think we need to discuss how one of the main barriers for folks being released from incarceration is the time that they're released at. I know several jails are releasing folks at 5 a.m., which does not enable providers to transport, get them into services on a really efficient way. Also, several jails just aren't necessarily having contracts or working with providers in the community to actually release folks to the provider so that individuals can immediately begin services. And in my experience, the first really 3 hours once somebody gets released is when they are at higher risk for relapse. And the moment that they relapse, I mean, I don't have the data in front of me, but a lot of these individuals become incarcerated within a week of being released from one incarceration episode.
Okay. Thank you, Marshall, for that. Also, I haven't heard too many people talk about drug court or the process of drug court. There's also diversion around some alcohol offenses and things of that nature. So if folks can that are familiar with those can at least talk about whether or not that's something they'd like us to consider evolving and enhancing and continuing to support. So I see we have Marshall. Sorry, not Marshall. Brandy, you're up next.
I'm not necessarily a fan of drug court unless the individuals that we're thinking about are ready to stop using. So drug court's only going to work if somebody's at a point where they're ready to quit, because you do have to be abstinent at some point within that first 3 months. And like Kendall said, it's really hard to do if you don't have a place to live and things of that nature, housing first. But all of this to me is very complex, even thinking about putting it all together. And so I'm hoping at the end of this that we suggest a work group to really flesh this out and really put the details together, because it is going to be a complex approach, because we're working with people with really complex behaviors, and it needs to have enough flexibility to be able to be customized and be client-centered. And so I'm hoping at the end of this that we do decide to set up a work group, because we're not going to get the answer out right here. But drug court, I think, is amazing, but it's amazing for people who are ready to quit. For those who aren't ready to quit, I think it's setting people up for failure.
Okay. Thank you, Brandy, for your reaction and thoughts. Marshall, I believe I don't know if your hands back.
When the drug court topic comes up, I worked for drug court for 4 years, and I am absolutely in agreement that it is an amazing model. The issue is people don't often know if they're ready to quit, and people are looking for a way to get out of incarceration. And in the event that it's true somebody is unable to maintain abstinence throughout the program, which most definitely needs to be more individualized. They find themselves in a very precarious position and will do quite a bit of prison time. So for those that successfully complete drug court, it's amazing, and there's so many success stories. But what we don't hear enough about are the individuals who are unable to successfully complete, and how much prison time they do, what ends up happening to them, how are they tracked, and I think that's data that we really need to have.
Okay. Thank you, Marshall. I appreciate your comments. John Hayden, you're up next.
Well, drug courts are an absolutely brilliant evolution in the court system. And there's a little misconception. We get an awful lot of people in drug court who probably aren't ready to quit when they first come in. But what we do is we provide them the structure and we provide them the resources. We do our best to provide housing. We do our best to provide medical attention, mental health assistance, all kinds of things. And it's not unusual for someone to start drug court with the notion that I'm just gonna beat a charge this way, and evolve to the point where recovery becomes their life. And we provide the structure in which they can do that. I am a big believer in autonomy, but I'm also a big believer in autonomy within a structured system that can provide a lot of resources to people.
Thank you, John. Appreciate the comments there. I thought there was another hand up, but somebody might have taken it down. Let's see. Addie, could you go ahead next, please?
Hi, thanks. I'm thinking of a program. It's not really a diversion program, and it's more for behavioral health, but because of the overlap with behavioral health and SUD, it's also SUD, but the VITAL program here in King County, which provides really extensive, wonderful wraparound services, including housing and outreach by medical provider and behavioral health. And one of the things that's interesting about that is that if I'm looking at this continuum, somebody would have to engage at Intercept 3 multiple times before they're even eligible for that type of wraparound service, and wondering how to bring those wraparound services into a person's life sooner rather than waiting for them to be incarcerated. I think it's 4 times or something they have to even be eligible to access those services.
Yeah, I think that was, thank you, Addie. I think that was some of what Malika was talking about some of the social determinants of health early on. But, and Malika, your hand is back up. Do you want to add on to that comment, or you have your own comment?
Yeah, so what I was saying was, in the framing of the conversation, to Addie's point, that it's important that we intercept earlier rather than not just whatever you just said around, but that we need to design interventions that are going to meet people earlier. It is not neutral to just look at this and say this is a neutral model, and anywhere that we encounter someone is what it just is what it is. If we're and this is also to Chief Tanksley's point earlier, Intercept 0 and 1, we can have more profound impact for the individual and the community oftentimes. Not that it's not meaningful to get them later, down the continuum. And I really think that it would be important for us to have work groups, to dig into this more deeply, and to also be able to include people that are maybe not on this particular committee, and that we're able to meet outside of this group, because meeting once a month, we're not going to be able to create the real meaningful responses. I think none of us are super interested in just, talking about this one time and saying that we did it. We want to create real meaningful change, and that's going to happen if we're able to meet outside of this group and have invite other people that aren't at this table.
Okay, thank you, Malika. Other comments? Feedback? One of the notes that Rep Davis put in the chat there is about equity in terms of particular populations and BIPOC populations, and whether we have access to the different diversion models that are out there, whether there's equal access. Any other comments or questions about diversion models? Now, the other questions, I think we've been talking about all three of them. What diversion programs are you aware of? What other diversion strategies have you heard that you'd like us to consider? And then diversion strategies before and after being booked into a jail or prison. So if you have comments on any of those three, I'd really like you to take a moment and let us know what your thoughts are. Hunter?
Yeah, so see, there's something that John said that stuck out to me about the autonomy versus the autonomy with structure. And see, I really think that structure could be very important. First of all, I think that having a choice and having freedom to take control of your life is also good. And I feel like some people could also really use that structure, especially when they're not fully sure if they're ready to put down their addiction. But I do think that if someone doesn't know that they're kind of on both sides, considering what they want to do next, I think that if they're considering stopping but don't know, I feel like that would mean that they don't want to keep going with what they're doing. So that's just kind of what I thought of what John said about structure that I think is important.
Thank you, Hunter. That's a really good perspective. And also it reminds me that when we think about the models, let's think about them not only across adult populations, but again, I'll come back to, I think somebody's mentioned co-occurring, but also young people. Do the same models work for young people? Do we have other types of models we'd like to promote for those that are, say, under the age of 21 or under the age of 18 that we would like to have folks consider? And, you know, there's lots of populations too. We have folks with learning disabilities and other disabilities that we have to be considerate of as we think about promoting new models. So love to hear your thoughts on any of that in terms of diversion. I'm going to ask Malika. I see two hands up. Malika, I'm not sure if yours was up and didn't come down or if you had another comment, and then we have Brandy.
Well, I accidentally left my hand up, but I'll just say what I said in the chat. Harm reduction is not the absence of structure. It is structure that supports a person no matter what. So I hope we don't get into a place where we're like one or the other, or there's like this, you know, this kind of polarization around abstinence only models and harm reduction models. So I just wanted to clarify, harm reduction is not the absence of structure.
Okay, thank you. And yeah, we have a very diverse committee here, so we like to hear all the different perspectives. And I agree. I agree on the idea that we need it all, and we can do it all. We don't have to have just one strategy. So, Brandy?
I just wanted to say, you know, we have this glorious opportunity here to really develop a system that makes sense. And I don't want, you know, this kind of came about after all the, you know, the war on drugs has been horrible to people of color, and we know this. And this is our state's attempt to kind of rectify that and make changes around that. And so I just don't want us to use structure synonymous with white supremacy. And so we want to create a program that works for the community and makes it better. And so, you know, we have to be willing to make sure that there's all different levels to this. And so I just don't want us to get stuck on the word structure, as it has been code in all other programs for many generations for white supremacy. So we need to make sure that we're making something that is for the community, that is going to get them out of this debilitating war on drugs.
Thank you, Brandy. And Amber?
I agree with Brandy. I just wanted to say that I do think it's important. I think when people are talking about structure, that they want to have you know, those SMART goals. Like, you want to have specific, measurable, attainable. You know, I think that maybe we could replace structure with just like talking about how the goals need to be you know, actually outlined and clear. You know, like we need to have, like, instead of just saying that people need to be in this box to, you know. I mean, I know maybe I wasn't clear with that, but I'm still my first cup of coffee. Forgive me.
Thank you. Thank you. We have a few more minutes. And again, I think that we've got really a great group with us here today. So I'm anxious, if you haven't had a chance to give your thoughts, please do so, because we want to hear all perspectives along these lines. Hunter, you're up again.
Yeah, thank you. So, yeah, those last 2 points, I think we needed to hear those, because I think, I mean, I guess personally, like when I think of structure, I think of it more as like having an assistance when it's needed, and that means something different for everyone, I think. So I think it's good being able to clarify what structure might be, even what assistance might be. Like I think personally, like back when I was struggling, I think, let's see, so I just totally blanked out on what I was saying. Like how structure means something different for everyone. Like some people need to have things planned for them, while others, when they don't know what to do, need someone to help them decide how to move forward, and provide resources to them. Yeah, thank you.
Yes, thank you, Hunter. Really appreciate your additional comment. John Hayden, you're back up.
Yeah, our drug court models, the model itself is proven to be very successful, and it needs to be exported to a whole bunch of other places in the criminal system. But very few of, in fact, none of our participants come into drug court voluntarily, in the sense that they went out and got arrested just so they could get into treatment. They came into the system involuntarily, of course. Then they're given a choice. They're usually given a choice of the drug court track or the traditional kind of track. And one of the things we find in drug court, one of the operating principles, one of the sort of golden rules, is that that structure and that immediate accountability and immediate response is one of the things that makes drug court extremely successful. But again, yeah, nobody comes in there voluntarily, and if we could reach those people long before their encounters with law enforcement, obviously we'd be a lot better off. The second thing you talked about, juveniles, it is apparent now, or is becoming apparent, the juvenile drug courts are far less successful than adult drug courts. The data just seems to be coming in year after year. There's a whole bunch of different reasons for that, I think, but my personal belief is there's a lot of better ways to reach kids than getting them once they've gotten into the court system, because that's just not working very well right now.
Okay, thank you, John. Appreciate the perspective. Any other comments? Give it a moment. All right, if not, we will take the information back. I know there's some comments in the chat as well. We'll take the information back as we think through this. We also heard from a couple of folks, so maybe it's more than a couple, that would be interested in having a little bit more of a work group on this. And so we'll take that recommendation back as well. And appreciate your thoughtfulness and feel comfortable sharing. You're all on here for really good reasons, and to be able to bring that voice forward is important. So thank you, guys. Appreciate that. And we are going to move on now to another part of the work that we're doing, which is around the Recovery Navigator Program that we're so proud to have had the opportunity to develop across the state. And it's been a whirlwind of a year, but we're really close to having just about every county have their staff on board. And for that, we're real excited. One of the things we need to do is give you an opportunity to have a bit of a light into the work that's happening. And so we're learning how to do that. And we've had some initial reports in from the regions. We're not going to walk through 150 pages of information with you. So we're trying to be a little smarter about how we collect information so that we can share it with you in a timely way, but also a practical way and an efficient way. So I think Jen Weinman, who is helping lead this effort, is going to take us through a little bit of a story of what we've done to date and what we anticipate coming down the road. So Jen, thank you for your leadership, and I'm going to turn it over to you now.
Good morning. Happy to be here. Thanks for allowing me some time to talk about some updates. Hi, my name's Jen Weinman. I'm the Recovery Navigator Program Administrator. So we put together a few slides to give some regional updates about the Recovery Navigator Program and the progression towards program implementation. So as Michael had said earlier, regions are almost fully staffed. So here's kind of a table breakdown for the 10 regions across the state. And it tells you essentially where each region is when it comes to having an opportunity to support clients through the Recovery Navigator Program. So the intended start date for Thurston Mason was in January. The start dates for the Salish region, certain parts of their region was able to start earlier, specifically Kitsap, Jefferson, and Clallam. So they were starting in December, and then specifically another provider in Clallam, PBH, is going to be starting in February, March, Peninsula Behavioral Health. So for Spokane, their region has kind of a split start date as well. February and March is likely going to be when their providers are up and ready to start supporting individuals. King County, their anticipated start date is hopefully in April. Pierce has been supporting individuals since November. Great Rivers should have an implementation of end of March or beginning of April, hopefully. Southwest has been supporting participants since December. Greater Columbia is hoping to start either this month in March or possibly in April. Some of these were a little bit fluid. There are different, there's different issues that have popped up for each region, but in general, these are the anticipated start dates. So for North Sound, they're likely to start March, potentially April, depending on how their process is going. And for North Central, they've had parts of their region going since December, and the remaining 3 counties should be starting April of 2022. So the 2 main things is that the policy coordinating group and operational work group, those will be, are in the process of being developed. Most regions have an idea about these groups, and that's been a focus for each region as well. So where we're at with BHASOs is a focus on training. So we're developing a training resource workbook with BHASOs. They've been invited to provide feedback, and we've got some great information that way. We're also working on a statewide RMP training curriculum, and the intended date for having that available is in the fall, in September or October for staff. Some of the focus areas are safe outreach and de-escalation, harm reduction, a trauma-informed approach, and motivational interviewing. And there's going to be a great learning opportunity coming up at the end of this month. It's hosted through the University of Washington, the Blake Series. And there's going to be a learning collaborative where RNP administrators and some providers can have an opportunity to listen in on lessons learned, implementation, and how regions are doing. And RNP administrators are also sending us their updates on PCGs and OWGs. So again, varying levels of development with where they're at with that group formation, but we're making a lot of progress towards having those groups formalized. So we're also looking at some of the data collection measures. So the current data points and the reports are focusing on participant case management, ensuring that there is outreach follow-up, a linkage to care and service plans, participant engagements and referrals, personnel lists and updates, and engagement reports. So the PCG and OWG for development and operations, engaging in community, including businesses, community groups, outreach programs, fire EMS, hospitals, etc., and success stories by participants and systemic change stories as well.
Okay, thank you, Jen. I think I'll pull up the slide with the data collection piece again, so we can take a look at that. Because what we're looking for from the committee is more feedback about what you want to see in the reports. This is part of the committee's role to be looking at those reports when they come in. So I'll go ahead and pull that one back up in just a moment.
Yeah, while you do that, I also I didn't know Jen, to stop you there or not, but there were 2 or 3 acronyms in there that I don't know that they were spelled out, and maybe you can I think it's a slide before. It's not on the screen right now, but there were a couple groups there that you were referring to that we just saw the acronym.
Sure, I think that may be the PCG or the policy coordinating group, and then the OWG operational work group. Would it be helpful if I type that in the chat?
Yeah, that would be, I think folks would appreciate that. Thank you.
You bet.
Yeah. And so, well, there we go. There's the data report. So this is the point that we want your feedback on. If there are other things that you want to know about the program. Now, some of us are new, right? This isn't, this is a new endeavor. And one that we're, again, just really uberly excited about being able to get outreach workers and case managers and such in every county and working in this model. But if you have questions about the model itself or suggestions and recommendations on what kind of data you'd like to see come back, I'm going to open it up, and this is the time to let Jen know what that might be. We say that we want the feedback, and we also understand there are some limitations in terms of resources to collect some data sometimes. A lot of folks will say, I want to see data and I want to see it, over a 5-10 year period of time. And those longitudinal studies sometimes, depending on how much information you want, can be a little onerous. But just no guardrails right now. Just please let us know what your thoughts are, and we'll see if we can't make it happen. So I will. Here. Okay, Jen, I don't know if you can see the hands up or not. I can call on people, or you're welcome to facilitate this part if you can see the hands.
I can see some, yes. So I think that might be Caleb.
Caleb's up
has
first.
His hand up. Okay.
Hi, Jen. Question for you. It came up at our first meeting. I want to ask it here again. It sounded like there's purposefully, per Rep Davis, not a centralized database to actually track people who get these services to monitor outcomes. Is there anything being done at the local level to actually track individuals so we can actually do evaluation and see who's getting services and what the outcomes are? Because I think what you're showing there are sort of the summary data that are reported in aggregate. And so for SOAR, for the SAMHSA SOAR work, for instance, we know everybody who's getting those services. They're required to report that, and then we can do evaluations. And we've been able to do some nice work, for instance, with jail releases to see that doing shared decision making, and people are more likely to start medications, which we can only do because we know who gets the intervention. So ideally, you track who got the intervention. On the flip side, less ideally, but not as terrible, is for the service providers to document the referral source. That's a very backwards way to try to do evaluation. But I'm wondering if any of those things is being done.
So there's data that is being collected at the local level as well. And so each region is going to essentially have to define, what they will be utilizing that data for. So they do have workbooks that they have to turn in with their quarterly reports once we get that piece finalized as well. But there should be some impact too at the leadership level on how they're choosing to handle some of that data moving forward.
So is
Jim,
it
if I
fair to
could
say
take
that
it
we're
to,
essentially not be able to evaluate the impact of this law in a strong measurement way?
Okay, so I think what Caleb, you're asking is, let's take it a different way. It's like your recommendation is, let's collect individual level data to an extent that we can tell what happens down the road. Now that could be name and birth date, people have lots of feelings about Social Security. I mean, whatever the identifying information is, if you can have some type of identifying information, then we can do a more thorough evaluation in the future. Am I hearing you right?
Sure, I guess you could frame it that way. My recommendation would be that a year from now, when contracts are reissued, that we have some way to actually evaluate whether this law is having any positive or negative impact, and on whom, if there's racial equity and access, if there's biased outcomes, all of those things. Yes, that's my recommendation, is that be done.
Okay. And Jen, I'm going to put you on the spot there again, maybe ask a little differently, but are the regions collecting any individual identifiable information at this point?
Yes, they have the ability to track their name. They can create a unique identifier. They can utilize their provider one ID number. So there are, with the metrics that we are collecting, there's an identifier for that participant.
So we are collecting that. Okay.
Yes.
All right. Thank you. I thought there was a little bit of disconnect there, so I want to make sure I was clear about that.
Sorry, just real quick. Jen, would they have to do those analyses locally, though, with their own analytic resources, I assume?
So some regions had hired staff to do kind of a deep dive on data, but that's not specific to each region. So they have to define kind of at their region level what they will do with that material. But if I remember correctly, there should be an opportunity for the policy coordinating group to have a piece on how data is handled as well.
Let me ask let me probe this a minute more, because I think it's important. In the reports back to this committee, it sounds like, Caleb, I don't want to read too much into it, but at a minimum, if we had a report back of the number of people we served and a bit about the demographics, that could kind of paint the picture a little bit more fully. I think if we can get that.
Can I jump in real fast, Michael? Can you hear me, Michael? It's Brianna.
Yep.
Hi.
I've got it. Yep.
So I am working with Jen, and we are working on ways to be able to report out on that. We don't have anything specific yet, but we are working towards using that data and creating more specific or broader reports that we'll be able to share with this group. So that is going on in the background. So just wanted to let you know.
Again, that's not evaluation, but that's at least giving a picture. And so I think as we put our list of things we're going to bring back to you, thank you, Brianna, that's something we're working towards. I just want to make sure folks were aware of that. And maybe we need to put on the list even the demographic picture or something, so we know, you guys know that we're going to bring that back to you. But let's see, Brandy, I think you're up next in terms of suggestions.
And I'm asking this question. I'll give a little context to why I'm asking this question about the PCGs. And so the policy coordinating group is straight out of the lead handbook. And so the policy coordinating group is who makes the decisions on the policies that the lead program will do. They're the big wigs, right? And so my question is, will they be starting the PCGs, the policy coordinating groups, before they start services? Because that's who kind of leads that portion of it. And so that's my big question.
We are encouraging regions to have their policy coordinating groups established and operating before receiving referrals. Good question.
Okay.
Okay, Malika, you have a comment? Thank you, Brandy. And
so this is kind of directed towards Caleb and some of the questions that he brought up earlier. We are Emily Kanafis-Soren, who works with us on data and evaluation for the LEAD model, which is the model that RNP is supposed to be designed upon. And to further Brandy's point, PCGs develop the framework with which the work is operationalized in communities. So it's great to hear that, you know, moving forward, regions are being encouraged to have that in place, regardless of where they are in their service delivery. However, to Caleb's point, there is no centralized data collection, but we are working through our TA with different jurisdictions to try and help them be able to paint a better picture of how system change is occurring in their communities. And we're hoping that eventually there will be capacity to be able to do that more on a state level. But we're doing that from the TA side. We're encouraging it as much as we can from the TA side.
Thanks, Malika. Any other feedback for Jen in terms of the data you'd like to see reported back to you?
Amber? Can you hear me?
Yes.
Somebody was kind of blinking out. Okay. So I just want to make sure that, because I do live in like a rural community that's not very diverse, I just want to make sure that that data is going to just reflect the lack of diversity in my region and not just be like grouped in with the data from like Seattle and, you know, like that it's going to stay regional, because I know that there is a super lack of equity in the more, you know, diverse areas and stuff like that. I'm not disputing that. I'm just saying, like, I would hate to see the data from the rural areas reflect on that. Does that make sense at all? Like, it's bad enough that there's a lack of equity in the more urban areas. But I think I just want to see the data reflect the community that it comes from. Does that make sense at all?
Yeah, I think Jen might be having some technical difficulties here. So yes, it does, Brandy, thank you. I think as we brought forward, what I'm hearing from you is as we bring forward data, let's bring it forward. You might want to see a statewide roll-up, but also see it broken out by region, that so we can tell whether or not demographically we're being reflective of the community that's there in terms of services. So thank you for the comment. Thinking Jen probably heard that, but I'm not sure. So
Sorry, I'm having some tech issues on my side. I'm back
And
in action. Yes, I heard you,
yeah.
Amber. Thank you so much. Great feedback. Thank you.
Jen, I'll help you out. I'll call on the hands, and then as long as you can hear it, that's the main thing, and then give you a chance to respond. So it looks like Brandy.
Brandy,
you're
muted.
There, sorry. I had another data question. So for one, I feel like we wouldn't be able to have that data in the first year because there has to be so many months for startup to get, because some of your programs are going to be starting from scratch, especially in your rural areas. The other question I had, is there going to be some kind of indicator within that data collection to look at our overall system gaps and not just with the organizations can do or can't do, because there's so many gaps in our crisis system, in our treatment system, that are going to be some serious barriers to how successful some of these programs are going to be, especially in the beginning. And so are we going to be looking at that data in a way to pull up the entire system, leverage the whole system to support these programs across the state? Is there going to be a way for us to look at that?
Yeah, that's a really good question. So I think kind of our intention this year is to really kind of nail down the metrics that we are going to collect, but will there be a larger evaluation for the effectiveness or how these resources are rolling out across the state? I would imagine, yes, we're definitely going to have a conversation, or that's going to be something that we need to discuss further down the line. Yes,
Yeah,
that's a
'cause I
great
think about
question.
I think about Amber's question. I mean, it happens in the urban areas. So you've done all this great work with clients, but there might not be an avenue for housing in her area. And so that's going to impact her success and all those kind of things. And so where do we need to leverage in her county to get more housing vouchers and stuff like that? So I hope we're able to pull that into there. And for us, for crisis, our crisis system does horrible work with our folks of color in our urban areas. So how do I factor that in when I have a very complicated person and have not been able to access adequate services because they don't exist? So I want to make sure that's written into that data.
So essentially asking like what would be the strengths and the weaknesses, right? Okay. Yeah, great point.
Yeah, so Caleb's hand is up again.
Definitely
Caleb.
should have
Yeah.
had more conversation on this and still be needed. But I think, if we look at HIV and the cascade of care framework they've taken, around 90% of people tested, 90% started on meds, 90% virally suppressed. What are our specific measurable goals for the 80% treatment gap for substance use disorder in this state? What are those goals? And what are the steps in that cascade of care? Is it 5 steps? Is it 10? Where are we? What are the proportions? Where are we losing people? Is it equitable? Who's getting it started on care? Who's completing care? So we need some goals and specific metrics to go at. And then we also need some uniform data. And so folks are aware, when we decentralized the state treatment system in 2016, the data were decentralized. And we do not have complete, accurate, comparable data on publicly funded treatment across this state. They do not exist. They don't exist. So I don't see how the way this is currently constructed, which sounds like it's even less structured than that, is not going to give this committee adequate information. So this is a serious issue that we're spending $45 million plus, and it's not clear to me at all that we can document outcomes. The characteristics of people doesn't tell us anything about, are we actually meeting individual and community goals? So I don't know where we're going to be in our conversation on that, but we won't know. We won't know whether any of this work is going to bear any fruit.
So Caleb, I'll address that for a moment. I think the Recovery Navigator Program, particularly at the investment level it's at now, is not going to solve all of our issues, right? It's not going to bring the treatment gap down all the way, things of that nature. So I think you're introducing something that's a little broader in terms of the plan going forward, in terms of if there are some priority goals for the plan, what might those look like? And then a variety of strategies will be necessary in order to address that. In terms of the data, yes, we did lose data continuity in 2016. We're in a better place today than we were a year ago. We have all the providers reporting now and into the behavioral health data system. And so we could talk about that at a later time, but we believe the data is getting back to a point that we can start using it again with confidence. So let me see it. Thank you. I guess the third point to that is thank you, Caleb, for bringing that forward. And something for the planning team to consider as we think about staging out all the elements of the plan. Do we have a broad overarching set of goals for the plan itself? So thank you. Jen, I'm not seeing any additional hands up at this point. Thank you again for all of your work and the work of your teammates. And as this has been quite a process, I hearken to.
Did you read the comment section? There was a comment in there maybe to Jen about a data work group before we end off if we're going to lose her.
Okay, yeah, I'll look at that just a moment there, Brandy. So anyway, I do want to give credit to Chris, or not to Chris, but to Tony Walton for leading the charge last summer and early fall to set up the standards for the group, and then all the effort to get the staff on and to lead the regions, and the support from the National Lead Technical Assistance Bureau for all the help that they provided. And so it is pretty cool to be here in March of 23 and see this program take off in all corners of the state. So thank you to everybody. Something. I'm not seeing the request. Oh, I see here at the end. To Caleb's point, can we have a data work group? We'll take that as your advisement in terms of the time we have and what we can fit in. But if we need a data work group, we'll take that into consideration, I guess, at this point. Okay. Any other comments?
Just real quick on what I don't know, Michael, sorry, just to see if there's a way to put a bow on this, is for the opioid response work group we have statewide. There is a data work group there. These issues really should intersect. So I think there are some existing groups. There's also the state epidemiology outcomes work group. I think that's still meeting. I'm not sure. So I think there are some groups, and this is such a major initiative. And the data elements we need to recreate stuff.
You're breaking up a little bit there, Caleb, but I think your comments about leveraging existing data work groups and such is appreciate that. We are not starting from scratch in the sense that we do have a state opiate response plan. We had a road to recovery plan. We have a state prevention plan for that matter, but this is more in the middle to end of the continuum work. So we are going to not forget those things and try to figure out how we can leverage them going forward. So thank you. All right, I think we're going to move on now to public comment. And if you have a comment to make, this is your time to do so, and we'll make a record of that. We'd ask you to, I think at this point, raise your hand or put your name in chat, and I'll call on you accordingly, and you'll have a couple of minutes to, I think we limit this to 2 or 3 minutes for public comment, and we'll make note of that. So, and the first person with their hand up is Lisa Dugard. Lisa, you're on the clock. Let us know what you're thinking.
Thank you, Michael. I don't know if I can turn my camera on. It doesn't seem so, but I just wanted to comment on, I have a number of possible topics, but the most central, I think, is the sequential intercept model discussion. It's really important that we think not of programs, but of a framework, a global approach that always works best for these issues. And that isn't, always and only intervene at intercept 0, but it is always create access to the kinds of support that work for people at the earliest possible intercept, and make sure, to the point that was the really important that was raised earlier about Vital, that the kinds of support that people really need to thrive and stabilize and recover are not only or primarily available once people get late and far into the system. Because when you do design an overall structure like that, you create incentives for well-meaning partners to drive people further into the system in order to get help. And we see this concretely all the time when law enforcement officers who absolutely, are trying to help, but have been told by a bunch of lawyers that if the law enforcement officer will just give the individual to the court system, that's where the real help comes. And so, of course, they make an arrest, they book somebody into jail, and they send the person off to be prosecuted in order to get help, because that's where we've put that investment. those incentives have to be reversed so that, warm handoff in the field without those unnecessary system involvements are easy and universally available. Because we do know, and there is an absolute mountain of research, that all other things being equal, being booked into jail, being prosecuted, and being convicted and being punished and stigmatized in that way is actively harmful. It's not neutral. And that is going to continue to happen to some people who use drugs, because people do commit other crimes that aren't going to be diverted, which is why an overall framework, not like one program here and one program there, but an overall framework that connects people back to care, provides continuity over time, over years, even when they do have charges that are not diverted, is the approach that will yield the most progress for the most people and benefit communities. So rather than looking at hanging different programs off of each intercept point, I hope that the committee will recommend an overall framework that has a bias toward the earlier intercepts, but recognizes that people will end up in the system, charged with actual crimes, and that nonetheless, the least possible system involvement is most conducive to stabilization and recovery. So that is why when we talk about LEAD, we say it's not a program, it's a framework
Sorry,
or a
Lisa,
process.
that's 3 minutes. If you want to finish your sentence, go ahead, but that is 3 minutes.
Yeah, that's all. Thank you.
Thank you, Lisa. Appreciate you being here today and giving your thoughts. Others, anyone else would like to give public comment today? Give it a minute. Okay. Well, again, thank you for guests, particularly for being here today. You're always welcome to have your comments go on record. So think about that for the next meeting. And I believe we're going to move now to next steps. And we heard a couple suggestions today with committees and or for potential committees. We are planning to start a committee related to recovery housing and recovery supports. We're going to kind of go from, if you're thinking linearly at all, go from the recovery support area. And then I think we're going to move to a committee on treatment and then to outreach and engagement. And then we'll consider the ones that came forward today as well. So Michelle, you're going to talk a little bit about how we're going to populate this, and hopefully the committee will engage with us. So go for it.
Yeah, so we are developing a work group, a subcommittee of about 20 to 30 people to focus on recovery housing and recovery support. And that would then generate ideas and go a bit deeper into this topic to bring back to this larger committee for consideration. So what we would love from you right now is ideas and feedback about how to assemble that committee, how to select these 20 to 30 people. There's already I think nearly 100 people interested, and so that just people from HCA staff, from other agency partners, from the community, other subject matter experts. And so, yeah, question one, suggestions for choosing committee members for this subgroup, this subcommittee, and then also who among you knows that you would be interested also in participating in a subcommittee on recovery housing and recovery support.
Michelle, how would you like folks to join the committee if they're so inclined?
Well, I think just emailing me or letting us know in the chat right now, raising your hand right now, to let me know that you're interested in being on this committee, or the subcommittee, I should say. And I mean, give it some thought and let me know. Brianna, are you on?
I'm
I'm
here.
trying to remember when, yeah, when I think it's April is when we were thinking we would have the first meeting. Is that right?
Well, so the inside HCA folks and just like a few of our interagent, like other agency partners at DOH, we are going to be having a kickoff this Wednesday, and then we're going to start developing on what these look like either monthly or biweekly. This is going to be like a sprinting work group where we're working for 3 to 4 months, meeting regularly, and coming back with ideas. I think the ask is less of how do you guys see people participating, and more is how would you feel having like those in the community also taking part in this kind of work group as well, um, along with us, because I feel like it's not just what we're doing at HCA, but I think the community still has a role in this as well. And so like, is that, yeah, community is welcomed. I think that they would be a great role. So it's like, if you guys are okay with that, then we'll start sending those invites out. The kickoff is for a half an hour this Wednesday. If you guys want to attend that, I can, I'm taking down the names right now in the chat, so I can shoot you over that that meeting notice. And if you can't make it, I'll send you guys a follow-up email after on what ideas we came up with about meeting regularly, and some of the uh, goals that we're going to be working towards. Yeah, the community should be prioritized. Yes, that's my thought too, Malika. So yeah. So yeah, we'll be, is there a way for Teams to automatically show the person speaking? I know, I'm sorry, Tank. My name is Brianna Peterson. I'm the technical plan developer and writer for 5476, and me and Alex, Sheehan right there in the corner of my screen. He's going to be helping me with this work group. So if you guys have anything specific, you can send a message to Michelle or me or Alex, and we'll be able to answer those for you. But yeah, so this Wednesday, so look out for that, and for regular meetings starting in April. Yes, so thank you.
And there is, like, for the work groups, isn't there a committee format that you guys have to utilize or something like that? That has a certain amount of representatives and all that kind of stuff?
So there's nothing outlined for these kinds of work groups out of 5476. So we're just working with you guys, the committee members, along with the working partners inside HCA who will be supporting that work, making sure that the right players are at the table is kind of where we're going from this point.
Okay.
Well, it seemed like in the law that there was somewhat of a framework, at least from like how many people are supposed to be in each group. And if we're saying that community should be prioritized, I mean, I understand having a point person to help coordinate stuff that's staff from HCA, but I don't feel like it's really appropriate to have like HCA heavy and in the complete position of authority when we're trying to be creative through this process and inviting community.
So they're there to help us make sure that the stuff that we're talking about we can do is basically what they're the ones supporting, that they'll be supporting the work, and we want to make sure that we're not talking ideas that are just not feasible. We want to make sure that even if we are out of the box, and my conversations with them, they're already out of the box. They're ready to go. So I'm not too concerned there. And I think as of right now, we have a good mix of individuals. And with you guys there, I think it just makes it even better. And I believe that the only thing that I read in 5476 was that we can have work groups out of this committee. There was no real dedication of who needs to be there or what. It's just we could have them.
But no specification on like certain
No.
experts, like, like if we're going to be talking about diversion, you might want a prosecutor on there, make sure we have a sheriff or a police officer, a certain amount of community members, a public defender. Like, if we're going to talk about diversion in a real way to put a plan together, we need to have some key people in the work group. I'm just putting that out there, so I'm assuming
Yeah,
there's some kind of framework.
no, totally. And that's why we're having the kickoff to like really see like who needs to be there, who needs to be in these discussions, and then reaching out and making those connections for these work groups.
So I think we need to, I'm going to put the pause button on here for a moment. This is not DBHR or HCA running off and creating something on our own, right? This is the SURSAC committee, and we have the option of offering some subcommittee work to be done for the SURSAC committee. So what we are doing is inviting you, if you would like to participate in a recovery services work group. We've gotten some feedback from the overall committee already that we're going to continue that conversation in some sub work group. The recommendations will come back to this larger group. It will be staff. There will be DBHR staff associated with this work group, because we may have to go down a lot of different channels and research a lot of different things to put together some recommendations. So we're blessed to have the staff, and we're going to use the staff to staff the work groups. The members of the work group will be from this committee. The ask today was whether or not this committee is open to having other community partners join in the work group. What we've heard, we didn't take a raise of hands, we could, but from a few in the chat and so forth, yes, let's open those work groups up to people who work in that space, recovery services space, to come in and talk about this. We'll have the same conversation when we talk about treatment. When we start talking about specific treatment modalities and strategies and things of that nature, we'll come back and ask the same thing. Who wants to participate in a treatment committee, and who else do we want to invite into that committee? So this is about process and getting things done in an efficient way so that we can have a plan ready, and that it's also about transparency. We're trying to be clear about who's going to be invited and such. A committee of 100 is not going to work. Typically, you want these groups 15, 20, 25 at the most, so that you can get the work done and move along. So it sounds like today we've got some volunteers, we've got some agreement that bringing in some outside people will be helpful. Any other comments to that or to my recap of that would be welcome.
So far, I've heard the larger committee ask for work groups on diversion and data and evaluation. And it's great that you're identifying these are areas of need. However, it seems to me that the areas that this group has identified are the two that I just mentioned. So are we going to build work groups around that too? Or are we only building them according to the ones that you're identifying?
So the recovery housing and support was actually a recommendation that was made in the last 2 meetings by you guys. So so we're listening and we're working off of that. So we're building off of that, and we are trying to start to develop what the other, because in my head I envision 3 different work groups going on for this, including like one for treatment, one for outreach and engagement, and then this recovery housing and recovery support services. And so we're developing on what those look like. This is just the first one we're able to get off the ground. So we are taking your considerations and we are moving forward with them. Thank you, Malika.
And to be clear, you brought up topics and we discussed them. So and we did say that they were important. So I'm not saying that I don't really appreciate the tone that you just brought there, but I think that they are important issues. However, we specifically asked for work groups on the 2 topics that were mentioned today. The other topics have been brought up in the other meetings by y'all, but they're all important. But the group specifically asked for the 2 that we asked for today.
No, and I understand, Malika. We do take those and we do work off of what you guys suggest. And the things that we brought up were stuff that are supposed to be in the plan that this work towards. So it's not like we're just throwing out ideas. We're basing it off of what the plan is asking this committee to do.
And there specifically in the law talks about groups about diversion, and that is what this group asked for.
Malika, no one is saying that we're not going to do any additional groups. We're starting with the 3 groups so we can get ourselves organized around the plan. We heard about the data group, the diversion group today. We said we'd take those into consideration. So I'm not sure where there's why defensiveness at this time. So other feedback on the recovery plan or thoughts about who to be involved? Okay. If not, then we do have just a couple minutes to close here. My impression is folks are getting more comfortable speaking up in the meeting. So thank you, Michelle, for organizing in a way that people are feeling that way, because we do want to hear from all of you. If you haven't had a chance to share your thoughts as of yet, please consider doing so at the next meeting. If you have, I hope you're feeling heard, and that we want to encourage you to continue to share your ideas. There's a lot to take back. We will take them back in addition to the additional work groups that were suggested. There was a lot of other ideas today as well. And so what we do is we kind of debrief these meetings, we go through, we look at which things we need to stick towards the plan going forward. And just like we did today, there may be a couple things we bring back and say, we heard a suggestion about X or Y or Z, but we don't have enough detail to think about how we want to move forward with it. And so we'll be asking for some clarifications too on some of your ideas that came forth today. But also I just, I did get a note from Rep Davis. In closing, she had to step off for a minute, but she too was impressed by the divergent points of view and the richness that came out today. So she wanted to give credit to the committee today for speaking up and having the conversation. So any other closing comments, Michelle, that we need to make today? Good.
No, I think that wraps things up.
Okay. Thank you all very much. I know this is very passionate work and we get passionate about it. So it's important. Those of us that have been touched by this substance use disorder know how important this work is. And so we're committed to get it done. And really thank you for joining us. Take care.